After all these years, his eyes are finally open, and he's looking at me. He's squeezing my hand. I can feel him.
Those are reflexive actions of his brainstem.
I have been coming here for 14 years, sitting by his side, waiting for him to look at me. And he is.
People have been known to wake up from comas, yes, but that's not Jacob. He remains in a persistent vegetative state. He's not in there, Annie.
How can you say that? I mean, how can you know, truly? This is the miracle I've been waiting for. My husband's back. And now you have to make him whole again.
I flew all the way from Chicago for this.
Sam, come on.
I'm sorry, it's just...
Your father's still in there, trying to talk to us, trying to communicate with us.
But he's not. I mean, why can't you see that? He's gone.
Mom, we know how badly you want Dad to still be here. We miss him too, but these are just involuntary movements.
Yeah, at this point, we're all doing involuntary movements.
You haven't been here. Neither of you have been here enough to see that these are different.
Are these different?
No.
Does our father show any signs of, what is it, higher brain function?
No.
And you told us 14 years ago that it takes more than a beating heart to declare someone alive. So, is my father alive?
He has no cerebral cortical function, so I would have to say no.
You listen to him, Mom, please? He told us this 14 years ago. He just said it again. How much longer do we have to be stuck at this never-ending wake?
Sam's right, Mom.
It looks so real.
We all want it to be real. It just isn't.
What would happen if we were to let him go?
We would remove his feeding tube. His body would be deprived of nutrients, and within few days, his organs would start to fail. But I assure you that he would not experience any pain or suffering.
He could hear us. He knew what we were talking about. He was begging for us to stop.
Mom, please.
Annie, that was an expulsion of air over his vocal cords. Just a reflex, like his eye movements.
I can't believe I almost made the biggest mistake of my life.
Dr. Kapoor, how long could he live if she kept the feeding tube in?
Conservative guess? Another 20 years.
I can't do this another 20 years. I can't. Goodbye, Mom.
You're leaving?
I don't know what else to do.
He's my husband.
He was your husband. And he was my father. I swear it's like you both died that day.
Sam, your mother...
Now she's tethered herself to this bed.
Never leaving the borough, never getting to know her grandchildren. It's 14 years wasted, and for what?
I'm not removing his feeding tube.
Yeah. Well.
So after watching Dr. Kapoor's take on this, let's talk about the real neurologists. What do they say? So Dr. Shah, can you please tell us the difference between a vegetative state and a coma?
Yeah. So in this case, we saw a person who's in a persistent vegetative state. What that basically means is person is awake, as was the husband in this case, and they have some reactivity, so like they'll blink, they can move their eyes, they may grunt or yawn or have some kind of vocalization. As the Dr. Kapoor said, there's no meaningful way for them to interact with the outside world. So, they're not speaking, they're not moving their arms. If you give them painful stimuli, they won't really remove it. And like you said, that goes down to the anatomy. In this case, like higher mental function is in the cerebral cortexes, and your brain stem, your midbrain, medulla, and pons, those control your reflexes. So like being awake, breathing, heartbeat, your reflexive stuff, that's in your brain stem. So in this case, if someone had loss of both of their cortexes, but their brainstem was okay, they'd be awake and reflexive, but no higher mental function. So the person, as you know them, wouldn't be there, but their physical body might still be alive. And coma is like, someone who's in deep and prolonged state of unconsciousness, they don't respond. And that might be from disease, infection, trauma, drugs, or medication induced. And that case, the person is unconscious as opposed to awake in this case.
That makes sense. Dr. Kumar, do you want to add anything on this?
So, Dr. Shah said perfect. This was perfect. This was fine. I don't think I can add anything. I would just want to ask Dr. Shah a question. So, I think that people from coma, there's a potential to get back, but I don't think vegetative state is reversible. Could you have to say something about that, Dr. Shah?
Yeah, I agree with you. So like comas can be, obviously being in a coma isn't a positive sign, but sometimes like we have patients who are in medically induced comas, like you said, for seizures, refractory seizures, other things.
Yeah.
So if it's medically induced coma, they can come out of it. If it's coma, which is temporary, like maybe acute brain injury, trauma, cerebral edema, something like that, if you treat the underlying cause and there is a reversible brain damage, they can recover. In general, to my knowledge, persistent vegetative state is like, if it's due to irreversible damage to your cerebral cortexes, then there's no recovery from that. And that's, as in this case, distressing for the family.
Yeah. So as you talked about this, this clip was quite emotional, as we can say. So how does the scene portray the emotional impact of patient's loved ones? So if you have ever interacted with those conditions and the patient loved ones, so how do you feel there is a connection between that?
So again, I've never dealt with such a but closer to this. Again, my experience is mostly from Civil Hospital Karachi, so I just generally speak about that. So there was this patient back in the ICU, neurological ICU, was working in Civil Hospital. So because he was there for like 2 months, and during my rotation in the ICU, I took care of him along with others as well. So he was more or less in a similar condition. He was just lying, he had a peg placed, peg tube placed. He was in vegetative state, I would say that, because there was no other patient. He was in a coma. His eyes were open. He would make good. If we pinch him somewhere, he would little bit maybe twitch his finger, something like that. So he was in a similar state, and again, in reality, I remember his father. He was a young boy, like he was around 25, 30. He had some these other, along with other difficulties. His brain was basically fried. He was in that state for so long, and I have seen his father caring for him, and he used to cry. He used to cry all the time. He was old. Poor old guy, and in Civil Hospital, we send lab results, we send lab tests which are not available in Civil Hospital. We send them outside to other laboratories. So we used to order such tests, and knowing that he cannot afford it, and the trauma that we are putting him through, but he used to do it. He would never say no to any such thing. He would just say that do whatever you guys can to make him better, and forget about the rest of the thing. I'll manage. And but we could see it in his what he's going through. I could never understand it, but the exhaustion, the emotional burden, it was too much sometimes, and he sometimes used to cry a lot to just vent it off in front of us. But yeah, so again, patient with this condition, I'm not sure what's appropriate for them, just to get him off the any kind of support, any kind of life support or anything, move the back tube or not intervene in any way, or do the opposite, just do the aggressive management. I'm not sure what is right, what is wrong, but I'd say that the family, especially and the wife or husband, the closer family, they have to go through a lot. They have to suffer a lot, and this scene is a perfect portrayal of that. The wife, she's reluctant. She's in denial that, and again, I cannot say anything how she's feeling. I cannot feel that how she's feeling. But it is very emotional. It's very traumatizing. It's very exhausting to manage a patient and their family, and seeing the family go through all of this. And even if we try to make them understand that this is not getting better, this is not coming back, and you will be exhausted at a certain point of time. You'll feel remorse that why not just taking care of him. But say the wife says that I want to take care of my husband no matter what, and then now if we break out of this commitment, it would be a little bit shameful. But this is a very, very emotional aspect of this disease. The family has to go through. I cannot even imagine. I just can see and can think and can give my medical opinions, but it's beyond our comprehension. Dr. Shah, would you like to add anything about that in what I said?
Yeah, I think I covered it really well. You talked about the emotional weight of it for the family and the clinician. I can tell you what, and it's really deepen your perspective. Obviously, if in a patient like that, the clinician can't decide whether to pull the plug or not. It has to be the family's input. And for that, just educating the family, just supporting them, empathizing with them, giving them closure, sometimes giving them like spiritual support if there are like facilities for that around. That can generally help. And just like, this is a very deep ethical thing, like what part of a person is worth saving and what part of a person makes the person alive or not. So like just having a conversation with the family, giving them time to process, and helping them come to terms and closure in their own way. That's some people do it better than others. I think you covered it.
Okay, so Dr. Sohail, I just have one question. Since you were mentioning this happened in civil hospital, and we all know is not full of resources in what it go with, or obviously we are just house officers, not decide anything, but what was the decision of consultants or senior doctors at that that case?
The thing is that she was in vegetative state. He just came here to the hospital with certain comorbidities, like he developed sacral ulcers at home. So he came to the hospital to get those conditions managed. He was, of course, diabetic, and then we were managing that aspect as well. He was also having some seizures along with that, so we were managing that aspect as well, and multiple other things. Not his vegetative state. We knew that he's not coming back from that. It's just, and to be honest, it was I won't say it was futile, but it was sort of aggressive management. It was sort of aggressive management in that case, especially in that case. When we speak about resource restrictions, now the thing is that we don't have that much beds in Civil Hospital Karachi. We have only 8 beds in neurological ICU, and I wouldn't say waste, because it would be very unethical and very unethical for me to say that. But if a person is with the least probability of surviving such one condition is occupying a bed, what about the person who needs it acutely and who can be easily managed with that? Now, just imagine for 2 months you're occupying a bed. And there's no additional benefit of it. He's not going to come out of it. He's not going to get better. We're just sort of managing his conditions. But the thing is, in the ICU, as long as you stay, you're going to develop 1,000 other conditions as well. You come here with sacral ulcer, you'll develop MRSA, you'll develop VR resistance bugs. So we'll have to manage that. And once you manage that, you'll develop C. diff due to the antibiotics. And when we manage that, you maybe develop another thing. So it kind of prolongs your stay a bit longer than we expect, than we always expect. So occupying a bed in that condition is in a resource restricted setup. I think it's a bit aggressive. And I'm not sure what we're consultant thinking at that time. I didn't never question their judgment or anything, but they were trying their best to manage his comorbidity. So we went along with it. But I'm definitely sure that we would if I were in such a decision-making state, I would definitely give that spot to some other person who acutely needs it and who has a potential of getting out of it, who has a probability of surviving good probability of surviving the disease. That's what my take on it. Again, I'm not a full-fledged neurologist or someone who's really well versed in such topics, but to the best of my opinions.
Yeah, so I'm not really sure about civil hospital, but Dr. Mustafa, do we need proper legal approval from hospital or from any other authority before removing them from ventilator, or we just need families' approval? There in US, I mean.
In the US, in general, there are 2 ways. One way is if the patient has no chance of recovery or minimal chance of recovery, like a massive brain bleed, massive stroke. We tell the family that this has happened. The patient's recovery will be very poor. They won't be able to, for example, talk, speak. They'll be bed bound. They'll need care. They won't be able to use the washroom themselves. It'll be a painful existence for them, if at all. And in that case, the family tells us, okay, my mother, father, whoever would not want to live like that. You can pull the tube or take them off the ventilator. We're okay with that. The other side is if the family says, no, do everything. We don't accept the possibility of letting this person go. And if there's no chance of recovery, like it's medically futile, and there is a medical emergency, other people need that bed, then it becomes like an ethical dilemma. You talk to an ethics board, you tell them the situation, they review it, and then based off the medical futility clause or reasoning, they can elect to take the person off the ventilator if there's someone else who needs it emergently. But again, that's a whole other ballgame with medical ethics and their decision making. Usually it doesn't go that far. Usually if you counsel the family well and support them and listen to them and explain things to them at their level, nobody wants to see their loved one living a futile, painful, bed-bound existence.
Yeah, that makes sense.
I'm sorry to. I'm just like to add some more to it. This perspective. So in US, where there are certain, you could say, like there are LTAC services, long-term acute care services. So in such some conditions, we usually, this patient is intubated and the family is not family says that we won't pull off the ventilator or anything, and then we usually consult social worker and but his job is to just organize this thing in a certain way that from the hospital to the next destination, where will the patient go? So we usually send them to the long-term acute care services. There they remain on ventilator under the care of the nursing and the family. If it's covered by the insurance, it's a good thing. Otherwise, family, if they won't pay for it, it's up to them. But again, the LTAC patients, I've seen those patients. They're like dead meat. They are like broken bones. There's nothing because a couple of days back, so I'm just saying my experience. A couple of days back, I was on call and we had medical code blue, so we went there to the 4 North side, so LTAC care building. So I went there, and I was the first one to arrive there. I was like, oh, where is everybody else? Because usually there's a huge rush of people. There are like all the nurses and doctors are everywhere. They're all there. And when I arrived there, only one nurse. He was trying to attach the defibrillator, and I said, "What's with the compression? Like, who's doing the compression?" And I started the compressions, and 1, 2, 3, one cycle, pushed 1 EP. Second cycle, he comes back. But additional thing, I broke his ribs during the compressions. And this is okay. It's not a big deal because you have to apply pressure during compression, and the compressions are really difficult too because you get so exhausted. Even in the one cycle, you're like sweating, all tired. It's a job. It's a tough job. So did one cycle, pushed 1 EP. Second cycle, he comes back. He comes back, and I was like. And I heard the sound of breaking his bones. He was a long term. He was on ventilator. He was on the tracheostomy. Yeah, I think I saw the tracheostomy replaced. Yeah, so he was on ventilator for a long time, and now you can imagine his bone was so brittle that I just during compression they broke. So then my senior came in. He said, "Yeah, you did a good job," and I was like. I'm not sure if I did a good job because I broke some bones today. And the patient who was such a debilitated condition, they say that it's normal. The long-term acute care patients, they are like it, and they will come back. They will come back within a couple of cycles. They'll come back. They'll achieve ROSC and they'll come back. But you cannot do anything else. You just see the medical alert. The only that aspect of it, just revert them back, and you just go do your work. But
this must be very, very mentally challenging for a physician as well, obviously. To make some decisions and to deal with them.
Exactly. It is. But again, it's people who are in persistent vegetative state or who requires long-term ventilation, and the family is reluctant to let them go or to pull off the plug. In simple words. So we usually send them to long-term acute care sometimes.
All right. Thank you so much, Amna. You can take over.
Yeah, so thank you so much, Dr. Kumar and Dr. Shah, for your valuable insight over different clips that we have seen earlier. I know it must be very difficult and, for the people to undergo these conditions, but early diagnosis will really help to eradicate this condition. So, Dr. Kumar and Dr. Shah, do you want to add anything?
I think we pretty much covered it. Dr. Shah, if you want to add anything.
I'm good. I think we covered everything.
Thank you so much, everyone. So that brings the end of the presentation. Now I would like to formally end this conversation, and inshallah we'll see you guys soon in the next conversation we'll have ahead. Allah Hafiz.
Thank you so much for having us.
Thank you so much.
I would like to ask our President, Saida Tayyiba Rehhan, if she would like to also give her input.
Hello everyone, Assalamualaikum. Good morning and good night from wherever you are joining. Thank you so much, Dr. Mustafa and Dr. Sohail, for joining us today and giving your insight and taking out time for the session. This was amazing. Thank you, Zaveria, and thank you, events team, for organizing this session. I hope you all had fun. I joined late because I have some exam coming up, so I'm really sorry about that. Yeah, sorry about that. So I enjoyed the session. Thank you so much, everyone, for taking out time. And I hope Dr. Sohail and Dr. Mustafa that we'll be seeing you in our future sessions as well. Thank you, everyone.
Yes, definitely. And one more thing, I just wanted to mention that this organization that you're carrying on, it's really amazing, and it's a good work. And I'm kind of I wasn't prepared for it today, but I'm kind of enjoying it. I cannot say for Dr. Shah, but I think he's enjoying it as well. It's a good initiative, and I'm like happy to be a part of it.
Thank you so much. The
Yes.
support that we received from you guys was amazing when I shared this idea with you, with Dr. Mustafa, with Dr. Shayan, and with everyone else. And the support that I received at that time really gave me the direction to start this thing. Thank you so much for all the support.
Yeah, thank you for organizing it. It's been a great session, and I love the enthusiasm and initiative you guys have taken. And hopefully, we can do more of these sessions.
Thanks a lot. Thank you. Over to you, Zaveria. You can continue.
Thank you so much for joining, Dr. Shah and Dr. Kumar. And Amna has rejoined, so if she would like to continue.